Shall I?
Yes, ma'am.
Good evening, everybody. We welcome you for this webinar hosted by the IFS South Tamil Nadu chapter. It's a monthly CME. We have every month a webinar that's being conducted since 4 months in a row. Now, I would like to start the meeting with a prayer song. Sagati, can we have the prayer song, please?
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு. கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. வல்லமை தந்து நீ வளர்ச்சி கொடு, அகத்திலும் புறத்திலும் மலர்ச்சி கொடு. வளர்ச்சி கொடு, மலர்ச்சி கொடு, வளர்ச்சி கொடு, மலர்ச்சி கொடு.
Good evening, everybody. I would request Dr. Ramani, the patron of this chapter of IFS, welcome all the people assembled here for today's meeting, and welcome the speakers as well. Over to you, Ramani.
Good evening, everybody. Happy Navratri greetings to all of you. And on behalf of IFS South Tamil Nadu, I am very glad to welcome Dr. Sheila Balakrishnan, who has been one of the pioneers in starting low-cost IVF in the government medical colleges at Trivandrum Medical College. And she has been a pioneer in this particular field, especially in low-cost IVF. And I also welcome Dr. Reggie Mohan, who is working along with Dr. Sheila Balakrishnan. Welcome to this IFS South Tamil Nadu meet. Then again, I have a grand, I have to welcome my dear friend Dr. Chitra Tyagaraju, who is an associate professor of OBGYN with a special interest in infertility, to this forum as a chairperson of today's program. Okay, then Dr. Lavanya is not seen there. Lavanya is another chairperson. And on behalf of IFS Tamil Nadu, I also welcome all the participants whose I think this meeting will not be a grand success. Welcome once again on behalf of IFS South Tamil Nadu. Welcome all of you.
Thank you, Dr. Ramani. And then as a secretary, it's my bound duty to tell you about the last minutes of the last meeting. Last meeting was on 13/9/23, and the chair were Dr. Gayatri from Tirunelveli and Dr. Shanti Rani from Theni. And we had Dr. Venugopal again from Kerala, who spoke to us on thin endometrium and how to deal with it and how to make it better and make it more receptive for patients undergoing treatment for infertility. Following that, we had Dr. Victoria Johnston presenting a case on thin endometrium and how she managed it. So we had about 49 people attending the meeting, and it went on very well. That is about last time's meeting. And I have a small announcement to make. We have the IFS fertilization coming up shortly. So people who are interested can look into the website, and I keep posting the messages that I get from the secretary office from IFS. So those who are interested can please register at the earliest and go and enjoy the program well. Okay, now we'll move on to the scientific session. I request the chairpersons to take over. We have Dr. Chitra here with us. Sakti, can I have the chairperson's CV? Dr. Lavanya is yet to join us. She's on her way back from Pudukkottai, so she said she'll join us. And we have Dr. Chitra already with us. She is from Pondicherry. She did a fellowship in reproductive medicine and minimal access surgery. She is the secretary of the IFS chapter Pondicherry. She has many credentials to herself. She is affiliated to the Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry, and won many awards. So she is the right person to be the chair for today's talk. And we first have Dr. Sheila, who will be talking to us about the trigger yesterday, today, and tomorrow. And Dr. Reggie, who will be talking us about low-cost IVF. Over to you, Dr. Chitra.
Lavanya has joined, Chitra. Lavanya has joined.
Welcome, Dr. Lavanya. Dr. Lavanya is our own society member, like Trichy OG society member. She's a director of Mallar Hospital, Trichy. She has also undergone a diploma in reproductive medicine at Germany, and she is trained in IVF at Sweden. And her special interest is, besides infertility, high-risk obstetrics as well. Please join us, Lavanya, and we are happy to have you here. Both of you all can take over and start away the scientific program. Thank you.
Thank you, ma'am. Thank you for this kind introduction. So I'd like to introduce our first speaker, Dr. Sheila Balakrishnan. Madam was a former professor HOD of Reproductive Medicine Medical College in Trivandrum. I think she started the first IVF center in the public center in South India. And also Madam has did a fellowship in UK for training in ART. She has a lot of contributions to our chapters in the textbooks and contributed to WHO, RHR. And Madam, very nice to know that you have been awarded PhD for a community-based study in PCOS in hearing address. We are waiting to hear you. You have a lot of experience. I'm sure this will really add on to much to the low resource settings. Over to you, ma'am.
It's not coming on the share screen. Not coming on the screen. Okay, 1 minute. Can you see my slide?
Yes, we can see. Make it full screen.
I'll make it into full screen. Right. It's again gone. What happened? Suddenly it went. What happened to my slide? Wait. I think it's just a minute. Yes. Is it okay now? No.
Yes.
Please click
Now?
on slideshow, ma'am, which is on the top.
Now it's full screen?
Yeah, now it is full screen.
Okay. Okay. Thank you so much for inviting me today, Dr. Remini, Dr. Chitra, Dr. Lavanya, and all of you. I thank the chairpersons also. And Navratri greetings to all of you. It's so nice, even at this time, all of you have joined for this CME. I've been asked to speak on ovulation trigger in ART. I don't know how many of you are practicing ART specialists, but still, they've asked me to talk. Even though it was past, present, and future, I think we are using everything. So it is very difficult to give a strict thing. So what is the aim in ART? It is a balance between optimal ovarian stimulation and the treatment outcome with maximal safety. So for us, safety is of paramount importance. So you have to minimalize OHSs and multiple pregnancies. And in the context of minimalizing OHSs is how trigger options other than HCG came to be explored, because we were always using HCG. So before we go on to the different types of trigger, I just mention a little bit, just a few minutes to what happens in a natural cycle. So in a natural cycle, it's very important that we all know that meiosis was arrested, isn't it? And so there is resumption in metaphase 1. So the final oocyte maturation involves resumption of the oocyte meiosis and transition from metaphase 1 to metaphase 2, and only at this time it attains competence for fertilization. And there is both nuclear maturation and cytoplasmic maturation. They are independent processes. Now, half the genetic material is from the egg, but all the membranous and cytoplasmic determinants are from the egg. We know that. So the oocyte maturation becomes very, very important. So this is the nuclear maturation where you have the loosening of the cumulus and that goes on. And then you have the cytoplasmic reticulum, where the initially you find the mitochondria surrounding the germinal vesicle, the organelles are distributed. Mitochondria gets dispersed, the first polar body is extruded, and you have both together. So there is we all know about the mid-cycle LH surge. Now LH we know is essential for final oocyte maturation and to trigger ovulation. And why does meiotic arrest occur? Because CDK1, which is expressed by the oocyte itself, is kept in an inactive form, and that is by cyclic AMP. Now, when you have this mid-cycle LH surge, it causes a decrease in the cyclic AMP and the cyclic JMP, both of which maintains arrest in meiosis. And this decrease of the cyclic AMP and GMP is essential to initiate meiosis 1 and go into meiosis 2. That's the importance of the mid-cycle LH surge. And as a consequence of the LH surge, what happens? It was tightly packed, the cumulus and the oocyte. So loss of the gap junctions between the oocyte and the cumulus cells, and there is cumulus expansion, the germinal vesicle breaks down, resumption of meiosis, granular cell luteinization has occurred, and this will cause a small increase in progesterone. And that increase in progesterone facilitates the action of estrogen to induce a concomitant mid-cycle FSH peak. So you have an LH peak and you also have an FSH peak. So the mid-cycle, why is the mid-cycle FSH peak important? It ensures there are adequate LH receptors. We all know FSH always induces LH receptors. So LH receptors on the granulosa layer are ensured. Synthesis of hyaluronic acid matrix, which will facilitate the dispersion of the cumulus. And thereby you find that the OCC, or the oocyte cumulus cell mass, becomes free floating in the antral fluid, which is again a prerequisite for ovulation. So with this basis, so we know yet you need an FS. In the natural cycle, what happens is an LH surge, there is an LH peak, also there is an FSH peak. And we actually, I'll come to the duration later. It usually comes down within 48 hours. Now coming to the different types of trigger which we have used, it's HCG, time tested, which has been used from the beginning. Then we went on to the GnRH agonist trigger because we were concerned about OHSs in PCOS. Then people started using, why not use a combination of both the dual and the double trigger. LH was also used, but not so common. Kisspeptin trials are going on. So I'll just touch upon each of these. So where do all these triggers act? So if you see HCG, both HCG or LH, they would act at the ovarian level on the LH receptor itself. Now, what about GnRH agonists? We know will act at the pituitary on the GnRH receptors, and that will cause both FSH and LH to be released. And kisspeptin, we know will act at the hypothalamus. Kisspeptin is responsible for a lot of things for the development of the hypothalamus, the pituitary axis. Release of all these hormones are because of the action of kisspeptin. Indeed, initiation of puberty is also. So kisspeptin is today coming in a big way. So just to show where the triggers act. So coming to HCG. Now, HCG, as I said, has been used for decades as a trigger, as a substitute of the endogenous. We know there is an endogenous LH surge. Now, the first cycle, the IVF cycle long back, was a natural cycle. And an endogenous LH surge was used to induce final oocyte maturation. But we cannot always rely on that. And that's why we use downregulation with an agonist or antagonist. And because of the inconsistency of the LH surge, and then we started using, you have to use HCG. HCG, you know, binds to the same receptor as LH, the LH-CGR receptor. They share the alpha subunit and 85% of the beta subunit. There's a lot of similarity between HCG and LH. Now, how does it act? It acts on the pre-ovulatory follicle, causing luteinization of the granulosa cells, resumption of meiosis, final oocyte maturation. There is a change from a predominantly estrogen. The follicular phase throughout was predominantly estrogen to progesterone synthesis. And immediately after the trigger, you find there is a rise in the progesterone. It can induce a spontaneous LH surge if the pituitary is intact. Follicular rupture occurs about 34 to 36 hours later. Now, the important difference from a natural cycle is the half-life. The half-life of HCG is prolonged. The half-life as well as the terminal half-life are both prolonged, whether it is HCG or LH compared to the what happened, compared to. So this is what happens. If you look at this in a natural cycle is the one in blue. When I touch it, it's just running away. And you find that it is much less. But with HCG, you find there is 5 times higher activity. And not only activity, this 5 times, it is also prolonged. So this is what happens when you give HCG. And that is why in PCOS, because of this, the very high effect of HCG and the prolonged effect, you find the luteotroph, the corpus luteum, all the corpus lutea are protected and they go on growing. And as a result, you find ovarian hyperstimulation occurs. So the consequences of HCG, there is an increase in LH-like activity, but no physiological mid-cycle FSH surge. Now that was, in the beginning, we didn't understand that, but later on we came to understand that the FSH surge, which occurs in a natural cycle, is missing. And the lutotrophic effect we know is very sustained, as I said. So you get very high levels of estrogen and progesterone, which in turn, when you have supraphysiological levels of hormones, it can lead to implantation failure. At the same time, vascular endothelial growth factor is increased, OHSS is more. Smaller follicles are also affected, so you can get delayed ovulation and prolongation of OHSS. And and in a non-IRT cycle, it can also lead to multiple pregnancies. So even though there is a very good LH surge, you find all these side effects which led to increase in OHSS. Now, what are the types of HCG? Urinary or recombinant? Cochrane reviews actually have found no difference whether you give urinary or recombinant. The only difference with recombinant is the batch-to-batch variability is minimized, and you know that they are filled with mass and not by weight. And so when you say there is so much, there is actually that particular amount. So you're very, the consistency, it is very consistent over batches. That's the main advantage of giving recombinant HCG. 250 microgram of recombinant HCG will be equivalent to about 5,000 units of urinary HCG. Actually, there is no difference in the yield between whether you give 5,000 or 10,000. Now, people have suggested when the BMI is more, should you give an increased dose? We still don't know because there are very few. There is no evidence to say that you should increase the dose. So at the moment, 250 microgram, or you can 5,000 or 10,000. Now then came the agonist trigger. Because of all these concerns about OHSS, we started giving the agonist trigger. And this was the initial paper by Iskowitz, 1988, where he developed the GnRH agonist trigger. And then I think this was again in Peter Humaden's paper in 2014, where he said that GnRH agonist facilitates a tailored approach to subsequent luteal support, taking into account the ovarian response to stimulation. And he also mentioned at that time that in the future, agonist trigger is likely to be used for trigger in all ANTAG cycles, and this was in 2014. And we all know that agonist trigger has become the standard of care in PCOS. Now coming to the difference, the pharmacokinetics, the blue is the natural, where you find that it is coming down within 48 hours. Now, the red is HCG, where you find it is very, very prolonged, and the green is GnRH agonist. Now, the advantage is the endogenous half-life is only 2 to 4 minutes. The terminal half-life is only 1 to 4 hours. When you compare with HCG, it's much, much less. The GnRH surge lasts for 24 hours only, but even the natural surge lasts for 48 hours. So this is the main advantage of the agonist, giving an agonist trigger. You find the luteotrophic effect is much, much less pronounced. Everything comes back to normal within about 24 hours. Now, why giving an agonist trigger? As I said, it was initially brought in to avoid the prolonged LH activity of HCG and in order to prevent OHSS in hyperresponders. So the main advantage is a very short, there is both an FSH and an LH surge, but it is a short mid-cycle surge. And also there is rapid and reversible luteolysis because of the short half-life, thereby decreasing OHSS when you compare to a HCG trigger. And when you combine an agonist trigger with freezing, cryopreserving all your embryos, you find that OHSS prevention becomes almost near total. It's almost total. And hence the standard of care today is to use antagonists for hyperresponders to keep the option of agonist trigger open. We know that if you give antagonists, you can use the agonist trigger. So giving the agonist trigger and cryopreserving all your embryos, most cases, would probably eliminate, definitely late onset OHSs would be eliminated, and even early onset OHSs would be minimized. What are the others? We found that again, when they gave agonist trigger, all these studies have shown that the number of oocytes, just a moment. I can't see my top of my screen. What do I do for that? Okay, never mind. Number of oocytes, the percentage of mature oocytes, and the number of top quality embryos are comparable in favor whether you give whichever you give. So it's all the same. The number of the oocytes, M2 oocytes, and the top quality embryos, it doesn't change whether you give a HCG trigger or an agonist trigger. Now, why? Even though LH and HCG act on the same receptor, there's a greater impact on AK, if you remember the AKT, which keeps it suppressed. So HCG generates higher intracellular cyclic AMP, which in turn will stimulate steroidogenesis, especially progesterone. The main advantage is that the FSH surge is promoted in addition to the LH surge, and all these together, overall, you find the GnRH agonist trigger results in a more physiological maturity. Applications of the GnRH agonist trigger, I think we're all familiar with it. Definitely in high responders, it would avoid OHSs, better oocyte quality and yield, and a reduction in luteal size. Absolutely no question, it is the standard of care. Again, in a donor programs where you want to minimize the discomfort or the risk to the donor, you will get a high oocyte yield. So donor programs also, it's always better to give an agonist trigger. Breast cancer patients, it reduces the post-trigger estrogen exposure in addition. All cycles undergoing freeze-all for any reason avoid primary OHSs. All this, it's always been, and dual stimulation protocols have also been started today. Now, what was the type of agonist trigger that you use? Most of the studies have been done with triptorelin or decapeptyl. 0.1, 0.2, 0.4 have all been used, and most studies in the dose finding studies were mostly they concur with 0.2 milligram. If you're giving leuprolide, you can give 0.5 or you can give 1 milligram. With glycerolin, you can give 0.5 milligram. There is no difference in LH profile, whatever you use. But as I said, dose finding studies are limited. However, probably the best option would be triptorelin followed by leuprolide. So this was a prospective randomized study with GnRH agonist, whether they compared agonist with HCG. And the conclusion was the agonist resulted in significantly more N2 oocytes, which many studies have shown. But this was when people started realizing that a significantly lower implantation rate and clinical pregnancy rate and a higher early pregnancy loss was seen in the agonist group, most probably due to a luteal deficiency. And that's because the half-life is so short. So why does this disruption of the luteal phase occur? Luteal phase is disrupted because of the short half-life. And so if fresh transfer is done, pregnancy rates tend to be lower. And that is because although similar to the natural cycle, it does not completely mimic the natural cycle because in 24 hours, everything comes down. In the natural cycle, the LH surge is actually consisting of 3 phases. There's a small plateau with a total duration of 48 hours. Whereas in an agonist cycle, it just goes up and comes down in 24 hours. There are only 2 phases, unlike the 3 phases where you have a ascending limb, a small plateau, and a descending limb in the natural cycle. So in the agonist, it just goes up and then comes down in 24 hours. So this leads to a significantly reduced amount of gonadotrophins being released from the pituitary. And as a result, you can have a defective luteal phase. So that was when concerns with, it was originally meant for PCOS where you were freezing all your embryos. But in cases, because we know PCOS is a spectrum, in very mild cases, you find the woman is very particular. She wants to, suppose you find the estrogen levels are low, the number of oocytes are not as much as what you expected, and you want to do a fresh transfer, what can you do? So this is just to show the difference, which I already told you. You can see compared to, you have 3 limbs, the 3 limbs, the ascending limb, the plateau, and a descending limb for the natural cycle. HCG just goes on like that, whereas agonist comes back very, very quickly. So this was a meta-analysis by Griesinger and Coliby-Angus, and they also said the likelihood of, ongoing pregnancy rate was significantly lower compared to HCG treatment because early pregnancy loss was increased. So this meta-analysis showed that it was the ongoing pregnancy rate was reduced. And that was when Peter Humedin came out with saying that what they did is they started adding a very small dose of HCG, 1,500 international units of HCG at the time of oocyte retrieval to rescue the luteal phase. And that's what they started in Europe. And they found that a small bolus of HCG when you give GnRH agonist secured the luteal phase, resulting in a comparable reproductive outcome in the two groups. And this is there are two approaches if you want to rescue the luteal phase. If you're particular to do a fresh transfer, you have the European approach and you have the American approach. The European approach was pioneered by Peter Humedin, where he, as I already showed you, 1,500 international units of HCG was given, but you continue the standard progesterone doses, whatever you've been using, whether you're using vaginal gel or oral or whatever. Repeated doses have also been tried, but then 2 doses, day 1 and day 4, but there is more chance of OHSs. Daily low doses, very low doses have also been tried, but I think the consensus is 1,500. Recombinant LH is also, that is another alternative when you want to rescue the luteal phase. This has also been tried. Giving LH, there's not much of a difference. Now, the American approach is giving very, very high doses of progesterone and estrogen. So progesterone 50 milligram IM daily. They insist on giving intramuscular progesterone and estrogen patches every other day. Estrogen has to be supplemented because the estrogen levels will be significantly lower following GnRH agonist trigger compared to the HCG trigger. And the recommendation is that the progesterone be kept over 20 if needed by adding vaginal progesterone. If it's not less than 20 with IM progesterone, which is highly unlikely, you can add vaginal progesterone, and the estrogen levels should be kept above 200 picogram per ml, either by stepping up the dose, adding patches or whatever, or oral micronized progesterone, all these things. So what did the Cochrane also said that, today we know GnRH agonist versus HCG for oocyte triggering in antagonist-assisted ART have been associated with low live birth rate, low ongoing pregnancy rate. Useful for women who chose to avoid fresh transfers, egg donors, fertility preservation, etc. So definite place when you want to, when you have the option of avoiding a fresh transfer. And you have 2 options. You can either go for a segmentation approach. You completely decide on elective cryopreservation. You're completely okay with that. You give GnRH agonist and you decide you're going to segment elective cryopreservation. The other option is if you're going to look at the serum estrogen, the number of oocytes, etc., you can give either you can give intensive luteal phase support or low dose HCG at OPU or at trigger. Now, before I conclude, just a few additions. So then people, what about giving a dual trigger? Because you had a disadvantages with the HCG, you had this is not for hyper responders. This is about other patients. You have a dual and a double trigger. Now, you found that yes, the combined trigger, that is giving a dual or a double, you find better oocyte or embryo quality with agonist because they found that compared to HCG, oocyte quality and embryo quality were better with agonist. And that was mainly because of the concomitant FSH, small FSH peak, which resulted in better oocyte nuclear and cytoplasmic maturation. And that's why people started combining the two, giving a dual trigger to improve yield and quality. But remember, it can only be given in those patients where you are not anticipating OHSs. You can take estrogen levels as a guide to decide whether to give dual trigger to improve reproductive outcome, especially when in the previous cycle you have not got you find it's an unexpected poor response, especially in the unexpected poor responders, Poseidon 1 and 2, there is probably a definite place for giving dual trigger. So if you're giving the dual trigger in poor responders, yes, you can give it 34 to 36 hours before OPU, in normal responders, 34 to 36 hours before OPU, especially when you find there are many immature oocytes. And the dual trigger group has shown, many studies have shown that there are statistically significant number of oocytes, M2 oocytes, and number of embryos cryopreserved with concomitant increase in implantation, clinical pregnancy, and live birth rate compared to the HCG only group. RCT has also shown the same thing in normal responders. What about in poor responders? Now, one major concern in poor responders is the high prevalence of premature luteinization which could be overcome by slightly early trigger. So dual trigger also has shown in the poor responders has also shown significantly higher fertility rates, clinical pregnancy and live birth rate. Early pregnancy loss was also less when you gave a dual trigger. So what about immature oocyte syndrome and empty follicle syndrome? Now, immature oocyte syndrome is when you have more than 25% immature oocytes after oocyte retrieval, despite correctly giving HCG for triggering and correctly timing your oocyte retrieval. Now, in a subsequent cycle, a dual trigger has led to retrieval. This particular paper in 2012 showed that it led to retrieval of significantly more number of M2 oocytes and more good transferable embryos. And they suggested it is due to the FSH surge in addition to the LH and HCG surge. So that's what in a Poseidon 1 and 2, where you have an unexpected poor response, it may be very good. What about double trigger? What is double? Now, that was dual trigger where you give both together. Now, double trigger is when the interval is different. You don't give it together. You give the agonist 40 hours before the OPU, and you give the standard HCG dose 34 hours before the OPU. So this is mainly useful in recurrent empty follicle syndrome, because in empty follicle syndrome, it may overcome any existing impairment of the cumulus expansion and final oocyte maturation. It can also be used, as earlier said, when the number of oocytes retrieved compared to the number of dominant follicles is low. So giving a double trigger in empty follicle syndrome is actually a misnomer, because even when we say it is a true empty follicle syndrome, and we all know what false and true is. So even in a true empty follicle syndrome, there is a school of thought which says it is probably a misnomer, because the follicles may not be actually empty, but it's rather that the oocytes are not aspirated or identified utilizing standard methods. So it may be due to impaired granulosa cell function, in which oocyte maturation is not resumed correctly, cumulus expansion does not occur, and as a result, you find the immature OCCs are resistant to follicular aspiration. And that's why sometimes you get just bits of cumulus. So in such cases, double trigger may help. And it's important to remember that the threshold for achieving an LHP could vary. We always say it's 34 to 36 hours, but some patients may need a slightly longer time. And some patients may take longer to complete the cumulus expansion at ovulation. And that's why the double trigger came in, where you gave the agonist at 40 hours. So in poor responders and poor responders, you could probably give it a little bit earlier, normal responders at the same time. And when you have abnormal oocyte maturation and empty follicle or immature oocyte syndrome and all those cases, you can think of giving a double trigger where you give it separately. Now, just a few words about how will you know your trigger is effective? Because we all have had cases of empty follicle syndrome, and very number of less where you find there were 8 to 10 follicles and you just get one oocyte or so. So can you, the fallacies of giving HCG trigger. Now, empty follicle syndrome is seen in probably 1 to 2% of cases. And you can say that you will do a HCG level. You can do a HCG level, yes, but it has been seen that HCG levels do not correlate with oocyte maturation. You can only say that it's unlikely to do, if the HCG is above a certain this thing, you're unlikely to develop this thing, but there is no definite level which tells you, okay, you'll get the actual number of how many follicles you have, you're going to get the whole lot of oocytes. So presence of optimal serum HCG levels was this thing that mature oocytes would be obtained at oocyte. You can only say that it's highly unlikely that empty follicle syndrome will occur when you have an optimal serum HCG level. Now, these optimal levels are not clearly defined. And HCG values on the day of oocyte retrieval of 40 many values have been suggested, but I think most of us would take 40. So anything more than 40, you take it as normal if you are doing if you want to do it. But usually we don't do it, but if you want to do it, you can do it. And does the agonist trigger? What about agonist trigger? Does it always work? Now, agonist trigger, always we say when there is a previous empty follicle syndrome, you can go for an agonist trigger. But again, you can get empty follicle syndromes. The incidence is similar to that with HCG. That's because of failure of the LH surge or the progesterone rise after giving the agonist trigger. So what can you do? How can you predict it? Yes, you can check your LH and progesterone levels after 12 hours. Now, what they say is they give a cutoff of about 50. They only say that if your LH is more than 15, it's unlikely. they're not saying that you can completely do away with empty follicle syndrome, but it's unlikely. If the LH is less than 15, they said the possibility of EFS is still 18%, which is quite a high number. A progesterone less than 3.5 also says that your chance of EFS is more. If the LH is more than 30 and the progesterone is more than 4, then you have the empty follicle syndrome is going to be just less than 1%. And if it's more than 50, you're going to get a very, very good successful oocyte yield. But usually we will take probably 30 or so as a cutoff. So LH monitoring may be a warning of a failed endogenous LH surge. So it is, if you're giving an agonist trigger alone, it might be worthwhile doing LH to find out if there is a failed endogenous LH surge, which can occur in certain categories of patients. And in such patients, you can give a re-triggering with HCG. Now, which are these patients? Now, these patients are usually when there is a, have you missed a hypo-hypo? If there is a hypo-hypo, only your HCG trigger is going to work. Now, hypo-hypo could be congenital, which, I mean, from the beginning itself, you know, most of these patients you would have diagnosed much earlier because you know there will not be any the spontaneous periods, and you know your levels will be very low and they will respond only to estrogen progesterone combination and not progesterone alone. So you're unlikely to miss it. But you can have an iatrogenic hypo-hypo, like prolonged use of the OC pill, giving it for 3 to 4 months can result in a iatrogenic state of hypo-hypo. And another thing that they say is the BMI is very low or very high, and it's much more when the BMI is extremely low. Also, they find that you have that chance of failures there, because probably because your estrogen levels are low. And so if your basal levels, we don't do basal LH levels usually, but again, if your basal levels are very low, less than 1, there's probably a chance that your HCG, your agonist trigger may not work. So just think, especially when you give prolonged. Now, interval between HCG and OPU, I've already said, there's no harm in a slightly extended interval. And they say it may even benefit some patients, especially in certain patients, especially when you've had a previous low yield, it may be useful. Now, coming to the last part, kisspeptin. It's not available, but still, kisspeptin works on the hypothalamus. It is a master regulator of GnRH. Now, estrogen exerts its effect on GnRH to the Candy neurons. Not going to the details. Kisspeptin 54, there are different types. 54 is the major isoform which is circulating in humans and has been used in studies. The half-life is only 28 minutes. So that we still don't know whether you need a second dose or not. So this was the first paper which came looking at, they studied in, I think this was in the UK. They looked at giving kisspeptin 54 to trigger oocyte maturation. And this was the phase 2 trial. Kisspeptin 54. Different doses were studied, 3.2, 6.4, 9.6, and 12.8. The highest yield was found with the highest yield was with the 12.8 dose, but the highest clinical pregnancy was with the 9.6 dose. There was no AOHSs, whether mild, moderate, severe, nothing was there. Oocyte maturation was also very good, 95%. So it's very, very promising. And the blue one is kisspeptin. The half-life is very short. So it may be a new natural option for ovulation trigger in ART, and that will completely eliminate OHS, but you have to further explore it in clinical trials before it can be used as a trigger. Now, just to conclude, this is for the future. LH, we know that there is a small rise in progesterone, which will start the LH surge and FSH, isn't it? So people started looking at that, and they said that probably this small rise in progesterone is important, and that is probably the trigger for the LH surge. So luteinization, the pre-ovulatory first wave of progesterone is independent of LH, up to 0.5 nanogram. That activates the GnRH pathway, and then you get an LH and an FSH surge. And then together, progesterone and estrogen create a fail-safe mechanism to ensure an LH surge. So probably now the thinking is that this small increase in progesterone triggers the LH. And if so, this could become a drug for the future, which might mimic natural ovulation. We still don't know. HCG still stands, so to conclude, HCG is still the standard trigger in most IVF cycles. Now, agonist trigger is mandatory in hyperresponders to avoid OHSs. There's no question about that. Also in an egg donor cycle, breast cancer again, because you want to reduce estrogen and private. Luteal phase defect is definitely more with agonist trigger. And if a fresh transfer is planned, you have to go for an intensive luteal phase rescue with either HCG or more preferably giving high doses of estrogen and progesterone. Dual trigger shows promise in normal and poor responders, and also when in immature oocyte syndrome. Double trigger in cases where you have had a previous empty follicle syndrome. And today you have newer options like Kisspeptin on the horizon, and that may completely eliminate coaches. Thank you very much. Be happy to answer any questions.
Thank you, ma'am. It was really a wonderful presentation. I mean, you've gone through the whole journey of all the types of triggers coming to the dual trigger, double trigger. And it really, I think nowadays the new thing, individualized gluteophase support, it also depends on the type of trigger we are giving. Absolutely. So I think you have come out with the very good points. Ma'am, I just want to know, you told in empty follicle syndrome, when it is follicles are not there, you try to cancel the cycle, and when you do this next stimulation, do you give that double trigger? Or there is some people will tell you, okay, if 1 ovary you have empty follicles, you give the trigger and try to do retrieval after 21st. What is your experience?
Yes, you're very correct. I think that is what we would do, because suppose you find an empty follicle, you find 1 ovary, you don't get any follicles. I think Chitra was saying the same thing today. You don't get any follicles. What you do is, if you've given a HCG trigger, obviously you will do a urine, I mean, you check the follicular fluid, or you check whatever for HCG, isn't it? And if you find it is a false, I mean, if it's a false empty follicle syndrome, you are definitely justified in giving a second shot of HCG and then planning for the trigger, isn't it? You can definitely do it. What I mentioned is about in a previous empty follicle syndrome. Okay, if she comes to you for the next time, then you probably will go for a, I mean, we used to say agonist trigger, but I think now you would go for a better than a dual trigger would be a double trigger, because the thinking is, there is true EFS and false EFS. False EFS is obvious because of batch to batch, whatever, or proper injection, all those things. We know that. I mean, true EFS, that's what I said. We are still not sure whether it's actually true EFS. They say the oocyte might be there. Only thing is the oocyte maturation has not occurred. The OCs are very tightly packed. You get sometimes very small bits of cumulus only, isn't it?
Yes, ma'am.
In such cases, they say some, in some patients, they may need a longer time. So that's the basis of giving the 40 hours, giving it at 40 hours and 36 hours. So that is when you have had a previous, but definitely in this particular cycle, I think Chitra, you want to share? I think Chitra was also talking about.
That's what, today morning, I was just telling her, today morning we did a pickup of one side and we left the other side. One side when we picked up, we never got any oocytes at all. That was again double trigger. We had given both the drugs and still we wouldn't get anything. So when we tested for HCG, it was negative. I mean, the serum HCG has not come the morning when I left the place. I think it was about only 39 or 40. So we are not very sure. That's what. So I have again given another shot of HCG and waiting to do the pickup tomorrow on the other side. So I was just sharing that with Sheila.
I want to know, if you are given urinary HCG, when you give the second, you'll give recombinant HCG.
I was telling her also the same thing. I think it's worth giving recombinant HCG because it's just one injection, isn't it? Whether you give recombinant for your stimulation is a different thing. That is different. It may not show, but for your HCG, because we're very worried about the trigger, isn't it? So I think it's worthwhile giving Ovidrel at least for the trigger. What about how often do you give dual trigger? In which type of patients? In your normal responders, are you giving dual trigger today?
Ma'am, we are not. Yes, ma'am.
We give for normal responders.
Yeah, I think even we have started, I think, for responders and normal responders. I think it's probably just peace of mind.
OHS's care is always there. What may come, what may go.
Yeah, hyper responders, I don't think, because hyper responders, if you have decided to freeze, it's okay.
Yes.
Most of our patients listen and they agree to freeze, isn't it?
Ma'am, we have some questions on the chat.
Yeah, please.
I think Dr. Anupapa Kiran has asked how to give double trigger. I think you already told how to give double
just
trigger.
A small difference between type.
And one more question by Dr. Ananta Lakshmi. How to rule out trigger failure in empty follicle syndrome if beta HCG is 39, 36 hours post-trigger? I think same thing.
If beta HCG is 39.
Yeah, 36 hours post-trigger.
The same patient I was discussing.
Same thing, just like her patient.
No, it is the same patient. Same
patient, is it?
No, Anandi is our embryologist.
Okay, 40 is probably, 40, what they say is if it's 40, it's okay. But as I said, you cannot definitely say because there's no cutoff.
Can't hear you.
No, you can't.
Can't hear you, Sheila.
No,
Dr.
no, no.
Sheila can't hear you.
She's
you hear me
audible,
now?
Chitra. She's audible.
Now?
Yeah. Audible.
Okay. Yeah, I think what Chitra said is the same, probably 40. 40 means there is enough HCG is what they say. So they say, so did you give a HCG trigger initially? Was it HCG initial trigger, Chitra?
It was a dual trigger.
Dual trigger.
It was a
trigger.
dual trigger.
Yeah.
So then probably, what about the LH? How much was the LH? No, you haven't.
We didn't do that.
See, if you're doing the LH, you should have done it at 12 hours.
Yeah.
After that, it may not. 12 hours doing an LH and a progesterone. So the LH is low and the progesterone is low. Definitely there is a place for giving one more trigger because you have to give it, isn't it?
Yeah. Some centers, I think they are regularly doing the LH and P4.
Yeah, I think for agonist cycles, if you're giving an agonist alone, it is sensible to do, you can do it.
Yeah.
But when you're giving a dual trigger, most of us will not do it, isn't it? Because that's why we are giving the dual trigger. Yeah.
Ma'am, one more question is there.
Yeah.
Do you test LH 12 hours post trigger to confirm LH search routinely?
That is what is
Well,
again
no, but for when you're giving, and I'm giving agonist alone, nowadays, recently we started testing for this alone, when you're giving agonist, but not for dual.
Okay. Yes. Okay. No more further questions. I think thank you, madam, for your wonderful
Thank you.
presentation. I will
Thank
go
you.
on to the next.
Thank you. And with your permission, can I leave? Thank you very much for inviting
Thank you.
me. I'm so happy.
Thank you very much, madam. In spite of you having a busy schedule, you have agreed to
Not
join
busy.
us. Thank you.
I have a guest and I have to go out. That's all. Thank you so much. All
Thank
of you, Dr. Remini, Dr. Chitra, both of you, all of you, please. Thank you.
Thank you, Dr. Sheila. Chitra, there is one more question. Chitra Tyagaraja, the chat box, that if it is LH and P4 are less after 12 hours,
repeat.
How do we time the trigger?
Then you have to repeat. If the
Yes,
LH is less,
that's what you have already discussed.
There's no
Now
question
we have
about
to repeat it. Repeat
It is
with the recombinant LH. That is recombinant HCG.
When you had HCG, definitely you give HCG because then you know that it's not releasing. So you have to give directly on the another mechanism. Yeah. When you do the advantage of giving both together is one is acting there on the
central
pituitary and one is acting directly, isn't it?
Yeah. So recombinant HCG may be given in such cases.
Yeah.
Okay.
Thank you very much, madam.
Thank you.
Thank you.
I think Dr. Lavanya will introduce the next speaker.
Lavanya.
Okay.
You can go ahead, Chitra.
Yeah. I know Dr. Regimohan is my very good friend, and whenever we are any Kerala conference, I think there is no chance I cannot meet him. Without meeting him, I'll never, any conference not complete. So I'm very happy to see him here. He's assistant professor in the Department of Reproductive Medicine, Government Medical College, Trivandrum, and he's a great laparoscopic surgeon and IVF specialist. Over to Reggie for the most important topic, the low cost IVF, which is mostly needed in low resource settings, which every patient wants it and every doctor wants it to cut down the cost of the patient. So let us see how it can improve the outcome of the patients. Over to you.
Thank you, Dr. Chitra, for your kind words. Am I audible?
Yes.
Okay. Good evening, Remini madam, Chitra ma'am, and all the distinguished attendees. Thank you for giving me the opportunity. Thank you, IFS South India chapter. So we met in UISR and Chitra madam asked me to present on this low-cost IVF. So I will be talking on low-cost IVF for the next 20 minutes. So I would like to sincerely thank Almighty as well as IFS Trichy and all the well-wishers. So I will be outlining my talk under the following headings. So as always, I tell in my presentation that we all stand on the giants who have already paved the way. Where we stand today is because of the pioneering works of the giants who did all these works. So remembering Anthony Leeuwenhoek, who discovered sperms, owned by Carl Ernst Owenbaya, then our own Patrick Steptoe and Robert Edwards, who had the first IVF baby in Oldham, England in July 25th, 1978 by a natural IVF. Then, of course, our own Gian Piero Palermo, who discovered ICSI, which revolutionized the treatment for male infertility. And as all of you know that there are so many IVF babies all around the world. And as Robert Edwards told that the most important thing in life is having a child and nothing more special than a child. And these are our first SAT baby, and that is our first Kottayam Government Medical College baby. And if you go through the current statistics in the world, as all of you know that IVF use is booming all around the world. Okay, starting in 1978 with the first Louis Brown baby, then nowadays almost 8 million pregnancies are there in the world and still counting. And it accounts for 1 to 3% of live birth in the United States and Europe. And as all of you know that India don't have that much of statistics to present with. So globally, the 2.5 million cycles, 2.5 million cycles are being performed every year. And in India, it's around 2 to 2.5 lakh IVF cycles that is performed every year. So as all of you know that the future is very bright. So many new IVF centers are every day booming up and up. And the value into 2021, the industry is valued around $746 million worth. Okay, and it is expected to double by 2027. So definitely we'll be doing around 5 to 6 lakhs of IVF cycles. So definitely we won't be jobless unless Robert replaces us, and artificial intelligence and robots replaces us. So my slides are not moving. Okay, so as Sheila Madam has already told, my own teacher, a great visionary. This was the first. Our center was the first center in government medical college and government sector to start, other than the AIMS and AFMC, to start an ART center under the great visionary leadership of Dr. Sheila Balakrishnan in 2012. And in 2013, our first IVF baby came. And then what happened is 2018, a Department of Reproductive Medicine and Surgery was formed. And we got the approval of the National Medical Commission to take the first batch of MCH in reproductive medicine and surgery, that too first in a government medical college other than AIMS. So we had now first batch has passed out, and now we are waiting for the fourth batch of students. We have 2 seats. So how expensive is an IVF? As all of you know that it is very costly to set up an IVF center, and maintenance of an IVF center is even much more costly. So you have to break even within 5 years. So say, depending upon the target, you have to break even the cost, how much you have spent for an IVF center and how much you are receiving from an IVF center. And definitely each IVF cycle costs you something, and you have to maintain the success rate. Suppose if you have a good success rate and all, your success rate depends upon your lab quality. So it's very essential to maintain the lab quality to maintain good results. And definitely profit should be there to sustain or to for our daily living. Definitely we are looking for good profits also. So if you look at the literature and all, in USA, the cost of an IVF cycle is around 12 to 16 lakhs. In UK, it's around 5 lakhs, 3 to 5 lakhs. In UAE, it's around again 4 to 7.5 lakhs. And in India, mostly it costs from, it ranges from 1 lakh to 2.5 lakhs. And as all of you know that this excludes the workup for IVF patients as well as the add-ons. So setting up of an IVF lab is always a problem. You need to have a good location. If you set in a very remote area where accessibility is not there, there's no point. You won't be getting any patients. Then you have to get the land and infrastructure. And if you come to know that in a town or a metro, to acquire a land and set up a building and all, it's very costly. And definitely in this era of modern era, you have to market yourself. For that also there is cost. You have to pay the electricity bill, you have to pay the water bill. Again, the regulations, the medical commission has come with newer regulations. You have to register, you have to yearly renew your things. Then the maintenance cost, especially if you are going for an AHU and all the the consumables and all that, you have to go for an annual maintenance contract with the companies and all. That also will cost a lot. Then you have to pay the staff salary, and of course, if you are taking loan and all, there will be the repayment of the loan. So all this can the slides getting stuck. Okay, so that's why you have to look upon the profit, and it has to be definitely on the highest side. So for this is a rough calculation. If you want to set up an IVF center or an XC center, that is a medium range, not a very low thing, or the very high-fi setup, you need somewhere around 1 crore. So your USC machine, if it's a good USC machine like Evolution and all, it may cost around 70 lakhs. But if you're going for a medium machine like Mindray or a Sonoscape or something like that, it will cost you around 20 to 30 lakhs. You have to have a minimum of 2 incubators. Ideally, it should be a 2-box type of incubator and 1 benchtop incubator, which can again cost around 20 to 35. If you add on benchtop, it's another 20 lakhs. XC machine will cost somewhere around 20 to 25 lakhs. Laminar airflow is a must. AHU again, if you are installing, it will cost you around 10 to 15 lakhs. Anti-vibration table, the aspiration pump, the heat stable area, the andrology setup, and almost all these things will roughly somewhere around 1 to 1.2 CR it will cost. So this I Googled and this was the answer. Is IVF treatment expensive? Yes, in India it costs around 2.5 to 4 lakhs, and there may be additional medicines and tests required or procedures. Suppose if there is a frozen embryo transfer, which can again further escalate the cost of IVF. So again, this is the main barrier for those, especially from the poor or the middle income group, to go for an IVF treatment. The high cost of IVF. So why it's so expensive in India? So again, this I Googled. Again, various factors like doctors' fees, clinical infrastructure, and the location of the center. All those things makes the IVF expensive in India. And again, what affects the IVF cost? This also I Googled in the web, World Wide Web. So again, the facility which you are getting treatment, the type of IVF you are pursuing, the number of cycles that are necessary to become pregnant, all this and the other optional services increases the cost. So coming to the economics of an IVF for XC cycles, your pre-investigation workup will somewhere cost around 5,000 rupees. IVF medications roughly cost around 60 to 1 lakh rupees. Again, IVF consumables like an XC needle or a holding dish, holding pipette, and petri dishes, all this can cost somewhere around 20,000. The professionals' fees of doctor, embryologist, anesthetist, all will come roughly around 25,000. And if it's a private setup, there will be an OT fee that is around 10,000 rupees. Lab fee again 25,000. Again, depending upon the number of straws, you have to charge them for freezing the embryos. Again, for thawing also, they will be charging. For embryo transfer another 5 to 10,000 rupees. So somewhere around 2 to 2.5 lakhs will be the total for an IVF or XC cycle. So what in India makes IVF expensive is definitely, as all of you know, that most of these patients are self-financed. Usually no insurance is there to back up the expenses of IVF, and there is no proper referral systems. Although there are some tertiary centers, still there are no proper referral systems. Unindicated procedures because of the lack of, because of the so much of moving of centers and all, some do unинdicated procedures. Then establishing and maintenance of a good ART lab, expensive drugs, upgradation and adopting new technologies, and lack of efficient manpower and risk of multiple diseases. These all contribute to make IVF expensive. So IVF cycle breakups, that is essentials versus optionals. What you can do is, these are the essential part of an IVF process. That is the pre-IVF workup, the ultrasound, the stimulation drugs, then the ultrasound again, coming to that is pre-treatment workup. You have to go with the different protocols. Then you have to trigger with the agonist or HCG. Again, ultrasound. Again, you have to go for the egg collection or the egg pickup, IVF and embryo culture. These are all quintessentials for doing an IVF and embryo transfer, and of course the luteal phase support. So what are the optionals which you can avoid or you can think of if you want to reduce the cost for an IVF? Okay, some centers routinely do hysteroscopy. You can very well know that from the trophy and the inside trials, you know that hysteroscopy is that not if there is no pathology, as if you do a good ultrasound scan or if the normal ultrasound scan is showing a normal architecture of the endometrium, there is no point in doing a hysteroscopy. Suppose if you want to rule out any cavitatory lesions, definitely an SSG or a saline salpingogram can help you, which is less costly. Again, the thing like CASA, that is computer-aided sperm analysis, which will cost you around 15 to 20 lakhs, is a luxury. Now, more and more people are coming with less expensive CASA, but they are not validated. Whether we can rely on those things, it's a point of question. Again, advanced ultrasound machines you don't need, although at the evolution and all, you get a better clarity of the image and you can transfer the embryos very clearly and all. But a simple ultrasound machine, which can be portable with a good resolution and all, will help you. You don't have to go for a bigger or a luxurious machines. Supplements, definitely so many people are supplementing pre-IVF, post-IVF, luteal phase support and all. You can reduce the supplements so that you can reduce the cost. The add-ons like the one size fits all, giving steroids for all, giving PRP for all, intralipid, GCSF, growth hormones, all this during stimulations again will add on to your cost. Again, hormone estimation during IVF, you need a pre-stimulation hormones like E2, P4, you do an LH, FSH, all those things which are usually unnecessary. And we used to do in the beginning of our institution when we started and all we used to do, but nowadays we hardly do any hormones, especially usually during the baseline only one set of hormones is enough. Again, whether to do an ICSI or an IVF in case of a non-male factor. Again, time-lapse, so many centers are having. Again, it's a luxury. Whether to go for a pre-implantation genetic testing, whether it is an nucleoide or for SM or for monosomy, again, it's a question. Again, nowadays, more and more papers are coming against doing a routine PGT. Again, sometimes unexpected things can happen, like problems during treatment. Sometimes you have to go for a freeze-all strategy. Suppose if she's going for a hyperstimulation and all, you have to go for freeze-all. You may be, especially for a hyper responder and all, you may be having so many straws to freeze. So that can increase your cost. OHSS again warrants admission. Sometimes you may have to tap the patient. Sometimes you have to monitor them with hormones, with ultrasound and all. That also adds to the patient's expenses. Then ectopic pregnancies and multiple pregnancies, definitely, if it happens, again, it adds adds to the unexpected cost for the treatment. So coming to the topic proper, that is how we can reduce the cost of IVF. Yes, it's possible to reduce the treatment. So you have several strategies. Either you can go for you can try reducing the cost in the pre-ART treatment during the trigger, during the stimulation, whether to go for a fresh ET or an FET. Again, avoiding newer gadgets. Again, some things you can do in the lab, and you can go for a reducing the number of prescriptions for the luteal phase support also. So pre-ART, again, what all you can do is, suppose if you are going for a tertiary center, as all of you know that age is a major factor. So as age increases, especially females, age increases, and once it crosses 35 off, the normal responder or a hyper responder slowly moves on to a hyper responder or a poor responder, which needs more hormones, more monitoring, and all those things. So the appropriate age to be referred, suppose if it's a male factor and all, don't meddle too much in a level 1 center or a level 2 center. You refer to an IVF center to get a proper treatment. Again, suppose if it's a tubal factor, again, there is no point in waiting much time. If it's a severe endometriosis, you have to refer them early so that she will get a better results. And again, for unexplained infertility, again, if you have tried 3 to 4 IUIs, you have to go for 3 to 5 ovarian stimulations and all. Then You don't have to wait much more. You refer them as early as possible. So again, whether to do an AMH or an AFC, again, we all are clinicians. We are all well versed with transvaginal ultrasound. So definitely your AFCs will be better. If you're doing the scans, if the gynecologist or the infertility specialist is doing the scan, you can rely on AFC. And AMH should be reserved only for poor responders, or the AFC if it is not that good. If the AFC count is less, or if you feel that she is a hyporesponder and all, you can correlate with the AMH. You know, AMH will cost somewhere around 2.5 to 3,000 rupees. So that can be avoided. Early referrals, as I already told, some centers even go up to 10 to 12 stimulations with oral ovulogens as well as injectables. They go for more than 6 cycles of IUI. Once everything is drained out, both the follicle, the egg quality, as well as money has drained out, they will be referring to an IVF center. So they will be reluctant. They won't be having any money and all. They will be going for a low-cost IVF and all. So early reference is another important thing. Again, as I told you, if there's a male factor, so many people are reluctant to examine the male, they will directly refer to an ultrasound sonologist for an ultrasound and Doppler. That will again cost around 1,500 to 2,000 rupees. Unnecessary varicose surgeries for severe OATs and azoospermias and all I've seen. Again, going for a DFI, which is again only for prognostic importance. So suppose if there is a recurrent implantation failure, then only you need to go for this the DNA fragmentation index and all. So that's another way to cutting cost. Again, I have told about uterine cavity assessment. So that is hysterosalpingogram versus a 3D ultrasound versus a sonosalpingogram or a hysteroscopy. As all of you know that a 3D ultrasound and hysteroscopy is costly. So if you have a normal ultrasound and if you can do an SSG, you can almost around more than 90% you can ensure that there is no cavity abnormalities. So coming to the pre-treatment costs, sometimes for 3-4 months and all, they'll be put on antioxidants, coenzyme Q, antibiotics to improve the drugs, to improve the microbiota and all. And all this microbiome, all those things and all are slowly coming up, but evidence is still lacking. So coming to the ART protocols, how to cut cost is how to determine the starting dose. I know so many centers, they have a fixed protocol. They will start with some FSH, some fixed dose of FSH. On day 5, day 6, they will be just converting into 300 HMG or something like that. So that again can increase the risk for hyperstimulation. You don't need that. Okay, and some centers we can see that you go beyond the recommended dose of 300 international units. So again, that is also not recommended. Again, what you go then again the deciding the type of gonadotropins is another thing. Whether you have to go for a recombinant urinary HMG or a highly purified HMG. Again, whether to go for long protocol or antagonist protocol. Whether you can add on your PPOs or a clomiphene citrate. Again, whether you are going for multi-dose ampules or pen. So all these can reduce. I will be coming one by one. So selecting the right protocol is very important. Reducing the cost of ovarian stimulation. You have to check the age of the patient, AFC of the patient, AMH if it is there, and you can calculate the dose. And then you have to, there are options for standard and minimal dose protocol. There is natural cycle is there, minimal stimulation protocols are there. There is something called the low intensity stimulation protocols where oral agents are used in conjunction with injectable low dose gonadotropins, not more than 150 international units. So definitely you know that lesser the gonadotropins, lesser will be the cost of the IVF. So let's see some of the evidence. This is a paper by Abha Maheshwari and A.K. Datta, published in 2021. They evaluated minimal stimulation, that is less than 150, less than or equal to 150 versus conventional dosing and IVF in poor responders, normal responders, and hyper responders. And they got similar live birth rate. Okay, so they got similar live birth rate, which indicates that both are equally effective. So you may be knowing the Optimus trial, which again reported that individualized FSH doses, that is 250 to 450 for predicted poor responders, or 100 units per day for predicted hyper responders for overall stimulation, result in similar cumulative live birth, okay, when compared to the standard dosage. Again, this tells that you have to go for an individualized controlled ovarian stimulation strategies, and you have to calculate the start FSH dose. So going into the economics again, suppose if you start with the 225 units of HCG, of gonadotropin for 10 days, you can see how much is the cost. Suppose if you use an HMG of 75 units, and if you're using 225 units, your cost will be roughly around 30,000. And if you are using HP HMG, that is highly purified HMG, the cost will go for another 15,000. If you're using urinary FSH, roughly the cost will be coming around 35,000 if you're going for 10 days. Recombinant FSH, you know the cost is almost doubling. Okay. And if you are adding recombinant LH to recombinant FSH, it's almost 80,000, 80 to 85,000 per cycle for 10 days. So just see the cost difference when you're using different types of gonadotropins. So as I told you, reducing the gonadotropins should be one of the options for reducing the total cost of IVF. This is again adding letrozole to the IVF protocol. And here you can see this paper have told that there is a reduction, the cost reduction was around 34%. So here in letrozole FSH dose, the cost was around 48,000 plus, but in recombinant FSH only group around 73,411 rupees. So there was a difference of 34% when letrozole was added into the protocol. So this is a wonderful paper from CMC Vellore published in 2011 by Eliama Madam and Kamath. Again, which told the importance of affordable ART. Okay, so they used clomiphene, I think, clomiphene along with HMG, and the summary was like this: low oocyte yield was there, oocytes retrieved may be of better quality. There were reported low pregnancy rate, no available cryopreservation. That was another drawback. There were no embryos for cryopreservation. But again, excellent laboratory performance should be there. And the cost and amount of drugs per cycle was less, the patients may need to go for another. So they may have to go for a multiple treatment cycles in order, because of the lower pregnancy rate per cycle of treatment. Okay, the cost was reduced, but again, they had to go for multiple cycles of IVF. So that was the conclusion. Again, this is again another very good paper from Aberdeen by Abha Maheshwari and A.K. Datta, where the mild versus conventional ovarian stimulation was compared in poor, normal, as well as hyper responders. The summary of the study, again, you can see there was no difference in pregnancy outcome in poor, normal, as well as hyper responders with respect to live birth weight, cumulative birth rate, ongoing pregnancy, and the clinical pregnancy rate. Again, the evidence was of moderate quality. Low risk of OHS was noticed in the mild group, especially in normal and hyper responders. Again, no generous agonist for ovulation trigger was given. Again, risk of cancellation was comparable among poor and hyper responders, but definitely it was increased in the group of mild stimulation IVF in normal responders. Again, the chance of getting a good quality embryo or a high grade embryo was similar in all the groups, that is all three groups, and in both stimulation strategies. So coming to the gonadotropin use, as I've already told about the economics of gonadotropins, the money difference which make when you go from HMG to recombinant FSH. So there are a number of trials are there. The landmark trials like Merit Megaset and Megaset HR have proved that HMG is almost equivalent to the results you got from these trials proves that HMG is almost equivalent to the recombinant FSH use, and there is not much of difference. Again, the Cochrane review came in 2011. Alinani. Again, this also told that there is not much of difference between recombinant versus urinary gonadotropin for ovarian stimulation in AMT. So you have to choose the gonadotropins wisely depending upon the patient's characteristics, whether to go for a urinary HMG or a recombinant HMG or a recombinant FSH or a urinary FSH. You have to choose wisely, and you can therefore you can reduce the cost of IVF cycle. So if when you're going for an agonist trigger, antagonist trigger, these are again roughly the cost involved. Again, if it's a 21 days, suppose if you are going for a Lupride 0.5 ml for 10 days, the cost is around 1,980. If you're going for a depot, which is preferred mostly by the infertility specialists, so that lesser number of injections, so that is around 2,500 rupees. And if it's an antagonist cycle, if it's a plain cetrorelix, it will cost around 6,820. But if it's a PFS or a pre-filled syringe, the cost is almost double. So there is not much of difference between a PFS and the normal cetrorelix. Only thing is the pain is less, the comfort is more with the PFS. So, but if you use a cetrorelix, normal cetrorelix, definitely you can reduce the cost. Coming to the HCG, which is used for trigger, as already Sheila Madam has told, there is not much of difference between urinary HCG and recombinant HCG. But again, the cost is a little high for the recombinant ones, especially the R-Hucog or the Obitril, which we use for giving trigger. So summarizing the COI strategies, the dose individualization of FSH according to the ovarian reserve testing as well as patient characteristics should be done. Second, again, you can use HMG instead of recombinant FSH and recombinant LH, thereby cutting the cost. Again, third thing is usually the antagonist. We all go for antacycle for our safety as well as for our comfort, but definitely the cost is more with antagonist cycles when compared to GnRH agonist cycle. Again, you have to always keep in mind that in hyperresponders or in those patients who are at risk for OHSS, GnRH antagonist cycle is always preferred. So coming to another point, that is the drug delivery system, whether to go for a multi-dose vial or a pen. So there is another good study which compared this multi-dose versus vials or multi-dose preparations. They found that there was more drug wastage, especially especially when the multi-dose vials are used. So a daily disposable pen could have reduced the wastage of 104 and 61 international units per cycle. And this is conducted in the Europe. So there was a cost saving of almost more than 100,000 pounds. Again, so many people do cycle monitoring very frequently. So usually we have to do once whether to start, when to start, if it's an antagonist cycle and all, day 5 or day 6, whether to start the and when to start the antagonist necessary. Then you go for a day 9 scan and to depend upon the when to give the trigger. So the number of ultrasound done during the cycle should be reduced. Again, endocrine monitoring only for those who is whether when you are in doubt, you can go for a E2 level or a P4 level. Okay, and again, when compared the monitoring response compared with ultrasound and laboratory examination, there was no difference on induction days, embryo quality, or clinical disease between the two groups. So two groups, one was monitored with ultrasound, another group was with endocrine, with also with the USG plus endocrine, and there were no differences between the two groups. So coming to the freeze-all strategy, this is a SWOT analysis of freeze-all strategies. We all do freeze-all strategies, especially when you're doing a batch IVF and all. But again, nowadays more and more papers are coming for going for fresh transfer and the importance of corpus luteum in a fresh cycle and all. So again, definitely there is advantages of freeze-all strategies like increased maternal safety, especially if OHS is suspected. Then improved pregnancy rates are there with freeze-all strategies, lower risk of ectopic pregnancies, and again, this SWOT analysis showed better obstetric and perinatal outcomes. Again, the weakness where only 3 RCTs were there, but now the new papers are coming telling that fresh, especially from Aberdeen, it's coming that fresh, you have to go for more and more of fresh cycles. So freeze all for all is a big question. So coming to the embryology or the lab aspects, again, usage of dishware, you have to minimize the dishware, you have to minimize the number of test tubes used, you have to minimize the media. So especially when you're doing daily cycles and all, this will be more. And there is a question whether you have to go for a droplet culture or a group culture according to your embryologist. They usually, most of the embryologists prefer to minimize the loss of medias. Again, whether to go for a single step media or a sequential media, whether you use mechanical cumulus cutting or use high-ACE. If you use high-ACE, it is more expensive. And the single step media, of course, it is more expensive. So droplet culture again needs more of culture media, it's more expensive. So another question is whether to do ICSI for all. Most of our embryologists prefer ICSI for all. More and more people are going for ICSI for all and less number of IVF. Again, the cost when you are doing ICSI for all, you need to have a holding pipette, you have to have an injection pipette, you have to have a special dish. Again, culture media, all these are more, which will again increase the cost of IVF. So even the question is whether if you do IVF, whether the hospital will reduce the cost of the treatment, or will the embryologist reduce her or his fees, professional fees, if he is doing IVF instead of ICSI. Again, I don't think so, because they all charge the same for IVF or ICSI. So it's not ideal. In an ideal situation or an utopian country and all, you can think of IVF rather than going for ICSI for all. So as I've already told about the newer gadgets, which is again very expensive when you're going for a PGT for all. Suppose if you're going for endometrial receptive assay, again, a paper has come, recent paper has come again, which is told that there is no role for doing ERA for all. Again, witnessing system, again, the companies are coming with double witnessing system, RFI witnessing system and all, which again will add on to the cost. Time-lapse imaging and morphokinetics, although it is very good to find a good embryo and all, but definitely at the cost of around 20 to 30 lakhs. And definitely it will be going to increase your treatment. Again, as all of you know, that always use your brain, and the best gadget is the human brain. So coming to our policy in SAT hospital is something is roughly like this. So usually our pre-stimulation workup for both male and female will cost somewhere around 3,000 rupees. We charge around 40,000 for lab charges, that is, which includes the embryologist fees and the disposables and all. And usually for a straw or first time freezing, it is usually 10,000 rupees. So coming to the stimulation cost, for suppose if it's a hyper responder, we usually start with 150 international units of recombinant FSH, which can cost around 42,000 for 10 days. But since our educational society is giving the recombinant FSH at a lower cost, it's around 30,000. So somewhere around 80 to 90,000. The cost of IVF for a hyper-responder will be somewhere around 80 to 90,000. And for a normal responder, again, we are using recombinant FSH, it's around 45,000. And if you're using highly purified HMG, again, special rate is there, but it's only 22,500 if you use for 10 days, and 40 plus 20 plus 10 hardly comes around 80,000. So we can finish the IVF cycle within 70 to 80,000 for normal responders and hyper responders. But for poor responders, definitely whatever you give, it won't be enough. And you can either go for an LH-FSH combination, definitely it will be costing more. And if you are using a highly purified HP-HMG, like an IVFM or something like that, somewhere around 1 lakh only the total cost will become. So we have special rates, we have special bargaining capacity with the pharma companies and all. And you know that the dydrogesterone, the original dydrogesterone, its MRP is around 829 for 10 tablets. Our hospital is giving at a rate of 43 rupees. So almost half the price. So we have special rates for almost all the drugs in our hospital. So in SAT, in our hospital, we do a controlled calculating dosing of the gonadotropins. We do very minimal workup and minimal monitoring. We usually go for a batching IVF because we don't have a luxury of a 24/7 embryologist. Again, cost factor is very much concerned because we cater mainly the poor population and the middle income age group. Usually we prefer for a fresh cycle, but again, nowadays we do more of freeze-all. But again, the cost is less, and customized luteal phase support is another strategy to reduce cost in our hospital. So to summarize, workup, again, selection of patients who need IVF is very important. Again, repeating tests like FSH, LH, AMH, and all those things, unnecessarily don't do all these tests. Again, only appropriate tests to be done. Again, in the stimulation, what are your strategies is look for candidates who needs less stimulation. Long protocol is better. Avoid aggressive stimulation. So usually if you don't see a follicle growing to 14 millimeters on day 5 or something like that, you would have a tendency to increase the gonadotropins from 300 to 450, from 300 to 600 and all. It's totally a waste of gonadotropins. So sometimes it may even lead to OHSS and all. And always we can consider adding letrozole to HMG. Again, you will be getting good quality embryos. Again, avoid unproven add-ons and supplements. Avoid routine estradiol estimation only if you are suspecting hyperstimulation. Then only, and if you want to go for a freeze-all strategy, or if you have to avoid a fresh transfer, do a estradiol estimation on the day of pickup. Sorry, on the day of trigger. Again, for luteal support, you don't have to add n number of progesterones and all those add-ons and all. Ideally, you need to have 1 or 2 progesterones in different routes. And also, you have to avoid, once you have a positive embryo, this thing test, you have to cut down the luteal phase support. Batching is another method to decrease the cost of IVF because it can decrease the usage of media, because these are all short expiry medias. The expiries are the expiry dates are very short. So batching can help you in reducing the wastage of media, and do ICSI only when it is indicated. And simplifying and standardizing the equipment procedures is another thing. So another strategy is you go for high volume and low profit. So the number of cases you do will be increased. And although there will be a low profit in a single case, when you do large number of volume, definitely your profit is going to increase. So again, careful patient selection, simplifying the investigative methods, reduce the cost of ovarian stimulation, simplifying the procedures and equipment in the laboratory, minimizing the complications of IVF. These are the strategies to reduce the cost of IVF. So as Dhirubhai Ambani told, his commitment is to produce at the cheapest price and the best quality. So you have to, it's a thing between money and quality. So you don't have to compromise the quality by reducing the cost of IVF, but you have to strike a balance between the cost and quality and the success rate. Thank you all. Thank you all for patient hearing. Thank you. And I would like to take the questions.
Thank you, sir. That was a very in-depth explanation of what all we need, basically, the basics to the luxury things. You have beautifully enlightened all the details, sir. Thank you very much. And
thank you, Alavani, madam. Thank you. Any questions?
Any questions here? So I think Dr. Ajay, you have given an overview of what is low-cost IVF, and each stage by stage, how we can cut down the cost. But finally, you have said that for the cost, the quality should not be compromised.
Yes.
Yeah. See, when you are using a letrozole plus HMG protocol, how do you use it?
We don't usually go for this letters only if suppose if there is an indicated case only. We don't usually go for this protocol usually. Usually we go for antagonist or agonist protocol. When we go for letrozole, we'll see for the first 5 days we just see. Then we start on the HMG, usually 150 to start with in a normal responders and all. And usual routine thing only. Then again, the dose of HMG, what we have noticed is the dose of HMG to HMG or FSH use is reduced when you are combining with the letrozole.
Letrozole, yeah. And especially when you want to go for a fertility preservation or pregnant, when they want, patient wants
you want the estradiol level to be in.
When the estrogen level you want to be very lower at a
within
lower level.
Control, within a limited control that like less than 1,000 or 1,500 and all, you can add on letrozole.
Letrozole. Anybody else? I think we have crossed the limit. Anyway, Dr. Chitra is held up. So on behalf of South Tamil Nadu IFS, I am greatly indebted to Dr. Sheila Balakrishnan and Dr. Reggie Mohan for their excellent talks today, which are very, very practically useful, not only for ART, those who are practicing ART, but also for any general practitioner, I mean, general gynecologist who will want to know something about the basics of ART. Okay, then also wholeheartedly, I thank all the participants without whose involvement this would not be in a fruitful IFS session. And then I thank the Shield Pharma for having provided us with a platform. I thank you one and all. And I thank Lavanya and Chitra for chairing this wonderful session. Thank you, Lavanya and Chitra. Thank you, Reggie.
Thank you. Thank you, ma'am. Happy Navaratri for all.
Yeah. Thank you. Wish you the same.
Thank you.
Thank you.
Thank you very much.
Tech support, I think we can find out. And I think this time we have a lot of people, not also Dr. Geeta, Kanna, Supriya, and so many people. It's it's appreciable that they have joined us from many places.
That's nice, ma'am. Thank you. Thank you, Chitra, madam. Thank you.
Thank you, Dr. Reggie. Thank you very much for joining us and giving us the general. Sorry, in between I had gone to deliver someone. Sorry. I couldn't stay hearing the whole of what you spoke.
But you can see in the YouTube.
Yes.
They'll be putting it in the YouTube shortly. We can share all the participants, the link, so that you can see that at your leisure. Yes. Thank you, everybody, for joining us for this evening. I thank especially Dr. Reggie Mohan and Dr. Sheila Balakrishnan for accepting to be a speaker for this evening. I asked Dr. Reggie and immediately he said yes. And even Madam, when we requested her to join along with him to give a talk on the trigger topic, she was also very happy to join us. So it's a great pleasure to have all of you here. And I thank each and every one of you for having been with us for this. I thank Chitra and Dr. Lavanya for being the chairpersons as well. Thank you very much. Thank you. Good night.
Good night.
We'll meet you next month with another interesting topic like this. Thank you, everyone.